Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.
Hi, everyone. I'm so excited to be here with you. I'm Bucci Nita, and we're diving into a topic that really impacts millions of patients across the globe. If you've treated AD over the years, you know that it hasn't always been an easy therapeutic, window that we've had. And now we're really in this golden era of treatment. We've got tons of therapies on the market. We've got tons to come. So I'm really excited to kind of take a deep dive into this today.
Absolutely. So my name is Shannon Moranti. I'm a dermatology PA from Naples, Florida, and I love treating atopic dermatitis. I think it's something that we certainly see in our everyday practice. So whether you see peds, whether you see adults, whether you see a combination of all ages, you're going to see atopic dermatitis.
So we'll start off with things that we used to use. We've got cyclosporin. This is an agent, I think, yes, old school for sure. We've got methotrexate, and then there's prednisone. And as much as we'd like to believe that we're not utilizing prednisone, it's still widely prescribed, and I think in derm and outside of derm. So let's get into some of that a little bit, and before we jump into some of the biologic therapies.
And how often do patients just say, "Oh, I just need the shot"?
Yep.
Right, like that one cortisone shot. It usually holds me over for a month, a couple months. And then we have to say, wait, time out. Like just because that was what held you over in the past and what got you better previously, that was a Band-Aid. That was a very short-term reduction in your symptoms. I think it behooves us to be the bearers of good news that there are so many better therapeutic options. And if we're going to put a needle in your body, let's put something that's way safer. So I think that's, this definitely should be something that we can let patients understand that there's so many better options out there. There could potentially still be a very important need for methotrexate, cyclosporin, oral steroids, but I really feel like we're getting away from that in today's day and age. So let's dive into the biologics. I always like to remind providers when you're prescribing a medication, like take into consideration what you're prescribing. The biologics typically will end in MAB, right, which stands for monoclonal antibodies. These are going to be cytokine blockers that specifically block a certain pathway of inflammation. And that's how I explain it to patients. Would you talk to us about the game changers in this biologic space?
The first on the market with us was the dupilumab. This is an IL-4, IL-13 inhibitor, and this was a game changer to atopic dermatitis. It's been an incredible medication, really has been life-changing for many of our patients. And some of the benefits that we're learning about later on after having this drug on the market, over 10 years now, is that not only is it highly effective in managing AD, but there's actually evidence to show there's a 32% reduction in the risk of the atopic march. So if you get your little babies on this medication early enough, you may prevent them from getting asthma and environmental allergies. So that's phenomenal.
Dupi also has the lowest age indication.
Yes, 6 months, right?
6 months of age and older, and it blocks both IL-4 and IL-13. So it is kind of blocking a lot of those really, truly key cytokines that are so they're just so detrimental in the atopic march. So it has been a game changer. Absolutely believe in that. Not only that, it can reduce the potential for further infections later, much decreased risk of infections and secondary.
And not just skin infections as we typically see with our atopic staff, but even upper respiratory. I was kind of blown away when I heard that information as well. So again, phenomenal drug, still highly utilized, and it's been a really big one in dermatology. Then soon after Dupi came tralokinumab. This one really focused on IL-13 inhibition. One of the advantages to this agent is that it did have the option for decreased dosing. So after you did the loading dose, if you were doing well, patients can drop down to an every 4-week injection. It's approved down to 12 years of age, I believe.
I believe so.
Yeah. And so that's been really helpful to have. Any thoughts on that?
So Tralo and Lebri are going to be IL-13 specific. So you're going after a much more kind of specific cytokine profile, similar side effect profile, with injection site reaction, potentially the eye conjunctivitis or eye irritation side effects. But really, I don't spend a ton of time on side effects with biologics. It's truly so nice that they have such a clean label and such a low low risk of adverse events.
Yes, no lab monitoring required with these agents. Very quick to initiate. If you're lucky enough to have samples in clinic, you can get patients on therapy same day. So it's really phenomenal to have these agents with Lebri being the new kid on the block when it comes to the IL-13s. The clinical trial is highly effective. It has apparently a higher binding affinity to IL-13. And again, still that really good safety profile. So we're excited to have that on the market now. And then we've got another nemolizumab, initially approved for prurigo nodularis, soon got the approval for atopic dermatitis. A different agent. It's targeting IL-31. And some of the benefits with this agent is the very rapid itch relief, some as early as 1 day, 24 hours of you having complete itch relief. That is incredible. And pretty low rates of injection site reactions with this agent. They do have a very interesting looking auto injector. I don't know if you've seen it before. It looks like a rocket ship.
I sure have. And it's very different. So for
Yes.
those of us who are used to prescribing biologics and hearing 2 clicks, it doesn't have 2 clicks. You have to actually mix the ingredients right before injection and you have to let it rest. So it's a very different process. Make sure that if you have not played with their auto injector demos, make sure you take the time to do so. 31 was always known as the itch cytokine. And I think I think they came out really strong stating that. And then we realized all the cytokines make us itchy, not just specifically IL-31. But this one does have a very unique mechanism of action going after that IL-31 cytokine receptor. So it's going to be blocking that IL-31 and very, very quick itch relief.
So yeah, we've, again, great biologics that we have currently. And then in the recent years, we've had some of these small molecules on the market, JAK inhibitors, 2 that are currently approved for atopic dermatitis, upadacitinib and abrocitinib. And I'll just kind of mention, we'll get into some of the details of it, but I do love to use these agents in patients who need very fast relief. These drugs work well and they work fast. While they do require a bit more on the front end as far as lab monitoring goes, we do know that these drugs are extremely safe. You talked about some of the black box warning already. We do have to give our patients really thorough counseling about that. And you do have to choose your patient appropriately, right? You want to make sure that you're screening for any underlying, chronic issues, kidney disease, any history of cancer, any history of serious infection. So screen appropriately, but these agents are phenomenal, highly effective, and really great to have in our utility. And not everyone wants an injection. So sometimes it is good to have a pill option that we can offer patients.
It's nice to have an option, especially for 12 and up, for upadacitinib and abrocitinib, to be able to offer to our teenage patients that are not such fans of injections and not fans of needles. But you really truly kind of have to take that dive and say, hey, let's rope them into that decision-making process and even truly talk to your teenagers. Would you rather take a shot every 2 weeks or once a month? And then do your moisturizers, but very little else? Or would you rather take a pill every day? And some people are going to choose the pill. And
Exactly.
as long as they are healthy and you've done your due diligence and you've done your workups, upadacitinib actually has head-to-head data with dupilumab showing that they do outperform and have slightly faster results. So for those who want truly fast reduction in that itch relief, I think the JAK inhibitors, since they are the systemic small molecules, can potentially give us a little bit of a quicker leg up on that itch.
Absolutely. So we're going to just briefly mention a few therapies on the horizon. So as if we need more, we always need more with atopic dermatitis. But a couple things I wanted to mention. One is delgocitinib. This is currently in clinical trials, hopefully soon to be approved for chronic hand eczema. Very exciting to have this. It's a pan-JAK inhibitor topical agent, highly effective in the trials. And
the data on this one is fantastic because it has a little bit of not only the type 2 cytokine, or type 2 inflammatory blocking, but because it is that pan-JAK blocker, sometimes with chronic hand eczema, you're getting a little bit of IL-17 involvement. You're getting other cytokines that we're not just seeing in specifically atopic dermatitis. Some patients with CHE only have eczema on their hands.
Right? Exactly.
Have full systemic, full-blown AD. So we need to be able to differentiate that and call a spade a spade. And if they do have variations of contact dermatitis or other things, we need to be able to tease those out a little bit. But if it's truly chronic hand eczema, and I think a lot more education will come as this product comes to market, I think it's wonderful to have a specific medicine for that disease state.
And then a couple other agents that are actually targeting very different things. We've got one IL-22 inhibitor, again, another cytokine that I was not aware of, but we're targeting it now. It's a drug called fezikinumab, currently in clinical trials, and apparently IL-22 has been associated with impaired barrier function, changes in the skin microbiome. So that'll be exciting to have on the market.
So that'll be another cytokine blocker. So remember, cytokine blockers work outside the cells, so those need to be delivered via injection.
And then one set of medications I'm extremely excited about, these are the OX40 ligand antagonists. So with these agents, they found that OX40 is something that's overexpressed in people who have atopic derm. It helps to drive that type 2 inflammation. And by inhibiting it with these agents, not only are we getting dramatically clear skin, but because it's targeting those memory T cells, patients are getting long-term remission even after stopping the medication. So I'm so excited to have these agents coming to market, hopefully in the very near future. So it's a good time to have atopic derm. I mean, it's a terrible disease, but it's so exciting.
It is a great time to have this terrible disease because we have so many options currently in our toolbox and new, really amazing medications to come. I think the OX40s are going to be extremely different than anything else we've had on the market. I think the way that they'll block the inflammatory pathways, it's going to be very, very different. And like you said, the fact that they can actually have a future impairment of those memory T cells to where we can get improvement even when we're off drug is really impactful and incredible for patients.
Couple things I wanted to mention. Patient support. There's always, we want to give our patients as much support as we possibly can. So there are a few things out there. The National Eczema Association, nationaleczema.org, has tons of incredible information that I actually utilize as a clinician to help guide my patients' therapy. And then Eczema Wise, it's an app that you can download. Patients can track their symptoms, they can track their triggers, they can upload photos of their flares, and they can keep track of medications that they've used so they can kind of show you and have everything in one, concise place. So really great resources for patients.
And some patients love an app. They love to be able to kind of chronicle things and take photos and kind of be a good historian. I think truly when we're counseling our patients, we need to keep in mind best practices. We need to take a moment to give some patient education on the disease state, the fact that it's not going away anytime soon. This is a chronic disease. This is not a bacterial infection that we can give you an antibiotic and it'll be gone forever. This will be something that we will be treating or at least maintaining for a good number of years or decades. So we need to come up with a really good long-term game plan.
Absolutely. I think setting those realistic expectations with patients that we cannot cure this, unfortunately, but we can certainly get it better, get them to live a good, normal life without having to think about their itch constantly. So I think that's really important. And patient education, as you mentioned, is really very helpful. I love handouts. Some patients, I'm a little old school, but some people don't like that. But handouts are great. Keeping the regimen pretty simple. I think it's much easier to do nowadays with these oral and systemic therapies, but a simple regimen will really get you better compliance with patients.
For sure. The more we prescribe, the less they're going to do because the patients typically will get very overwhelmed. So keep it simple, keep it concise, allow patients to understand why we're prescribing certain things, why we're recommending certain things, but write down the order. It's amazing how just writing down step 1, like after shower, apply your medicine first. Then apply your moisturizer. Patients are like, oh, thank you. I didn't know which one to put on first.
Please make them take a photo of your written instructions in the room. They will lose that paper half the time. So it's really helpful to have that in their phone. They can always access it.
For sure.
And then really giving patients access to you. We know most of us have EHRs. We've got great patient portals. I think patients oftentimes, they feel like VIP treatment when you do give them access. Messages come directly to my inbox. My MA can reach out and respond, but it's really helpful to have that open communication and really offer them pretty close follow-up. Copays are high, deductibles are high, but patients still want to have that hand holding. They still want to be taken care of. So make sure that you're following them closely, especially early in the management.
So wrapping it up, there's so many new advances. There's so many wonderful medications on the market. There's so many exciting ways to treat atopic dermatitis.
Absolutely. And I hope this episode really helps you guys feel encouraged about how far we've come, energized about what's to come next. We hope you found this content really helpful. Please subscribe to the podcast, leave us a review or just a quick note if you loved it. Share it with your colleagues. And thank you so much for tuning in. Please stay tuned for future episodes of the Skin Sync podcast on Apple Podcasts, Spotify, and our website, Elevate-Derm.com.
Thanks for tuning in to Skin Sync. Don't forget to subscribe on iTunes or Spotify so you never miss an episode. We'd love to hear from you. Send your topic ideas to admin@elevate-derm.com. If your suggestion is featured in a future episode, you'll receive complimentary registration to one of our upcoming conferences. To explore more of Elevate's educational and career resources, visit elevate-derm.com.